And now I'm recording. We're going to record this for the third and final time. Okay, conception. Let's get it on. Let's hope it goes faster. All right, conception and fetal development. I'm more concerned about fetal development than I am the conception. So you can read about all the concerns about conception. You should have learned this in A&P. And I hate to say that, but you should have. Gametogenesis. Basically, the only thing I'm concerned about is, fertilization occurs in the ampule of the fallopian tube. Implantation is going to occur usually in the anterior posterior fundal region between 6 and 10 days. So basically, I want you to know that maybe a couple of weeks after person suspects they're pregnant, they may have a little bit of breakthrough bleeding, and that's okay. Well, I got some fertilization pictures here. You can see where the sperm is going into the egg, and it'll only allow one sperm, where we have some really bad anomalies going on if it don't. This is where the egg and the sperm come together, and the cells are dividing, and that's 2 weeks. And then I have some pictures that you guys can look at your leisure. Well, the Nugo, which is baby here, is 5 months old, 20 weeks. Got a lot of eyebrow hair, and you can see it on their face. They usually have a lot of lanugo at this time. Babies 24 weeks can hear outside the uterus, so if there's a loud noise, they can actually hear that. They will be born with all the hearing they're going to have. They'll have their full hearing ability when they're born. And of course, all babies should be so happy. I wish my baby was that happy. My baby being me. I'm my baby. Okay, there's a difference between the embryo and the fetus. A pregnancy is 10 lunar months, which is 40 weeks. We have 3 stages. We have the pre-embryonic, the embryonic, and the fetal. Our pre-embryonic is from conception till day 14. This is when all that cellular replication is going on. The blastocyst is forming, the ectoderm, mesoderm, all these things, embryonic membranes, all of this is occurring in up those 2 weeks after conception. Our embryo, then it becomes an embryo after day 15. From day 15 until 8 weeks. It's going to be only 3 centimeters long from crown to rump. That don't include its feet, right? Be aware that it is the most critical time in the development of organ systems. This is where teratogens and can cause some harmful developments in the organ systems, and congenital anomalies can occur. So this is the most important time in the development of the fetus. During this time and during this development, all of our organs and our external structures are going to be present, and we're going to be able to identify this embryo as a human being. So remember, it's very small, it's 3 centimeters. It's going to be tiny, but we're still going to be able to discern that it is a human. And everything that's going to happen and develop happens in that 8 weeks. The rest of the time, the systems just continue to grow and become what they should be. We have implantation of the 2 fetal membranes that form the chorion and the amnion. The chorion forms the umbilical cord. The amnion forms the amniotic sac. Amniotic fluid develops from diffusion from maternal blood. There should be anywhere from 8 to 1,200 milliliters present when they're born. There's always a constantly changing volume of amniotic fluid simply because of the way it diffuses in and out. Babies swallowing and peeing in there, so there's always a difference in the volume changing. And it's never the same amniotic fluid. It's not like it's a stagnant fluid that's been in there for 9 months. It's constantly changing. Some of the functions amniotic fluid serves: maintains body temperature. It's a repertoire for waste, maintenance of fluid and electrolytes, allows musculoskeletal development by keeping the infant from getting too squashed, cushions the fetus from trauma. It also allows for fetal lung development and acts as a barrier for infection. So all these things are going on. The volume is very important for the fetal well-being. If it's less than 300 oligohydramnios, it's associated with fetal renal anomalies. And if it's more than 2 liters of amniotic fluid, hydramnios or polyhydramnios, it's associated with gastrointestinal and other types of malformation. So we can learn a lot of things from all the stuff that the amniotic fluid contains. It contains albumin, urea, creatinine, bilirubin, all sorts of things. So we can actually have some genetic studies. We can learn what sex the baby is and if there's any markers in the chromosomes that we want to see about. The yolk sac is where the amniotic cavity and the amnion form. The yolk sac is going to aid in carrying maternal nutrients and oxygen. So that it takes the job of the placenta until the placenta is able to take over that position. By the end of 3rd week, which is at 4 weeks, the primitive heart starts to beat. So everything, the yolk sac is going to cover all the things that the placenta would do until the placenta is able to take over them. Our umbilical cord is formed at 5th week. We have 2 arteries, 1 vein. The arteries carry blood from the embryo, and the 1 vein carries blood to the embryo. It can have a true knot, which means there's actually a knot in the umbilical cord that prevents blood supply from traveling to and from. This will cause fetal death if it's a true knot. If a baby's born with a knot in the cord, and yes, it's definitely a knot, it's not a true knot if there's circulation is able to continue through the umbilical cord. Wharton's jelly is the substance that is around the veins inside the umbilical cord that protects those veins from collapsing and continue on with their job. Nuchal cord is if you have cord wrapped around the neck, and battledore placenta is when the umbilical cord is not attached in the center of the placenta but on the edges of the placenta. It is normal for it to be in the center. So what about our placenta? Our placenta functions as an endocrine gland. It functions for metabolic exchanges. All the little cotyledons all form the placenta. There's little pieces of them. If one piece is missing, then we have to go in and hunt for it. The HCG is what we determine the pregnancy level, if they're pregnant or not. The HPL and progestin and estrogen are used in maintaining the pregnancy. So our placenta has metabolic functions. It has respiratory in that there's oxygen exchange between the maternal blood at the placental membrane, passes over to the fetal blood. There is no exchange between maternal and fetal blood. The placenta also stores and delivers the nutrients through the umbilical cord. The arteries are going to carry the excretions away. The placenta also serves as storage. It can actually store these nutrients as the baby needs them. The function of the placenta depends on maternal blood pressure. If the maternal blood pressure is hypertensive or hypotensive, there is a decrease in blood flow to the placenta and therefore a decrease in the function the placenta is able to do. And if it's hypotensive, then the fluid volume is not getting there. If it's hypertensive, then the vessels are constricted and the placenta is unable to get the fluid there. Fetal maturation. Once the embryo stage is over at 8 weeks, we then become fetal at 9 weeks to birth. Viability has been an ongoing problem as far as determining where it was. When I first started, it was 20 weeks, did up and down, period. In the last few years, there has been an ongoing movement to try to get the viability to be at least 22 to 25 weeks, but so far the ACOG, the American Academy of Gynecology, are not bulging on this. They are saying they're leaving it at 20 weeks because every once in a while you can actually save a 20-weeker. Limitations on survival of a fetus that's born at 20 weeks is based on their CNS function and the oxygen capacity of the lungs. Fetal circulation is how the baby manages to oxygenate him or herself inside the uterus, and it's very different than external circulatory system. And at the precise moment of birth, everything converts from fetal circulation to pulmonary circulation, and it's very difficult and a very crucial time for the infant. The cardiovascular system is our first organ system to function as part of a system. During that 4th and 5th week, that heart's developing into a 4-chamber organ. So if there's going to be any atrial septal defects going on during the division of those 4 chambers, then it's going to occur here in that embryonic stage. Some of the things that are unique to the cardiac system is the ductus arteriosus and the foramen ovale. And here is you a nice little picture of the foramen ovale. And what the foramen ovale does is it allows blood from the right side of the heart to circulate into the left side of the heart. Now, in adults, the left side of the heart has more pressure than the right side of the heart. In the fetus, the pressure is the same in both sides of the heart, but the lungs have a higher pressure gradient, and therefore blood is bypassed with the patent ductus by the ductus arteriosus that connects the pulmonary artery to the aortic artery and allows the blood to bypass and come back into the pulmonary vein instead of the pulmonary artery, or the aorta, excuse me. There's 3 special characteristics that's going to enable the fetus to obtain sufficient oxygen from maternal blood. First of all, the hemoglobin carries 20 to 30% more oxygen than its mom does. Then the hemoglobin concentration of a fetus is about 50% greater than the maternal. Then you have a fetal heart rate that's quite fast, 110 to 160, so that the cardiac output per unit of weight in the fetus is higher than that of an adult. Your hematopoietic system comes from stem cells that are going to be seated in the fetal liver, and hematopoiesis begins there during the 6 weeks. It makes the liver look large. Gastrointestinal, this is going to develop within anywhere between the 4th and the 6th week. You're going to see a lot of the development of all of the systems. Again, this is occurring in that embryonic stage. And these are still in the embryonic stage, and where you're going to see a lot of your common abnormalities of your digestive tract are in that hindgut. So the fetus is going to start swallowing amniotic fluid at around the 5th month, so he's in the fetal stage. Gastric emptying and intestinal peristalsis starts to occur. And our placenta is definitely taking care of our nutritional needs and our elimination. So there is, the gut's not working. The placenta is still taking care of that. The gut's just getting ready to work. Near term, the fetus is going to accumulate waste products known as meconium, and it's a really dark, tarry, sticky substance. Those of you who have babies know exactly what I'm talking about. Usually, right after birth, it can take up to 24 hours for meconium to pass. This is important that meconium passes. If meconium does not pass, or if a plug passes instead of a meconium, you might be looking at cystic fibrosis. So you want to be sure to notify your doctor if you do not have meconium pass within that 24 hours. Breech presentation, or the presence of hypoxia, will cause meconium to pass in utero at times. So a lot of times you will have what we call meconium stained fluid. And there are special things we have to do at birth when we have meconium fluid. Other things that might be causing the failure of meconium to pass is atresia. You may have an imperforate anus. You may have an ileus in there. So those are some things you might want to investigate. Clinical significance. 26 to 30 weeks gestation, they're going to start laying down stores of brown fat to help support their metabolic system, especially if they get cold stress. It burns faster and more efficiently than regular fat, subcutaneous fat. So by the time they're 36 weeks gestation, their GI tract is mature. Hepatic system, glycogen stored at 9 to 10 weeks, and it's this glycogen is the major source of energy for the fetus and then the neonate. If the maternal iron is sufficient, then the baby will be able to survive with the right amount of iron for up to 5 months after birth. So a lot of breast babies are okay without adding iron to their diet. Of course, our babies with formula that has iron in it, you don't ever have to worry about that, but they do have to worry about gastric upset. So in fetal life, the babies don't conjugate, or the fetus doesn't conjugate bilirubin. It's cleared by the placenta, so the fetus never learns to do that. Once the baby's born, the enzyme that's needed to conjugate the bilirubin is not in necessary amounts to conjugate the bilirubin, so then the neonate, especially the little pretermers, are going to be subject to hyperbilirubinemia. Coagulation, that's usually assisted by the functions of the liver. Our factors 2, 7, and 10 aren't able to be synthesized because we don't have vitamin K in the sterile gut. Once the gut is introduced to food, breast milk, or formula, vitamin K starts being introduced into there and starts synthesizing it, and then it will start synthesizing factors 2, 7, and 8. That's the reason we give vitamin K to our newborns, is because of that sterile gut and the lack of vitamin K in it. By giving them the IM or vitamin K, we're giving them the ability to coagulate. Respiratory system, believe it or not, it starts developing in that embryonic stage and continues through about 8 years old. After 24 weeks, we're going to start seeing pulmonary surfactants starting to be developed and line the interior of the alveoli. And then after 32 weeks, there should be enough surfactant that's going to provide the infant with enough lung alveoli capacity to survive. So pulmonary surfactants in the amniotic fluid, we can also use those to determine the degree of lung maturity. Lecithin is our most critical alveolar surfactant required for postnatal lung expansion, meaning after they're born. We can usually detect it at 21 weeks, but it should increase by quite a bit after 24 weeks. The sphingomyelin surfactant is going to remain in constant amount, so it is going to be our constant measure. So we have a ratio L to S, which we call the LS ratio, to determine lung maturity. A 2 to 1 indicates maturity of lungs, unless there is something that might affect that it should be higher. This usually going to occur about 35 weeks. Some of the conditions that are going to affect lung maturity is maternal hypertension, placental dysfunction, infection, and corticosteroids. Fetal hypoxia, baby has some type of injury in utero, mom has hypertension, anything that may stress the baby can actually cause the baby to have increased blood levels of corticosteroids. That's going to accelerate the alveolar and surfactant development, which is a good thing, so that when they're born early, they will have more surfactant and be able to survive. Maternal diabetes and chronic glomerular nephritis can actually delay lung maturity. So if you do an LS ratio on these patients, you will need to see a 3-to-1. At 11 weeks fetal, you're going to see, you can actually see respiratory movements. It helps aid in the development of chest wall muscles. You're going to have fluid in your lungs. It's going to expand the air spaces in the lungs and in the villi. Then it's going to drain into the amniotic fluid, or it's going to be swallowed by the fetus. Right before birth, it starts to decrease. During the birth, during the vaginal squeeze, they usually lose about a third of that, and the rest of it's usually absorbed or reabsorbed into the bloodstream within 2 hours after birth. Renal system forms the major portion of amniotic fluid. Oligohydramnios, as we said before, is renal dysfunction. And even though we have our renal system beginning to function, the placenta still excretes and maintains electrolyte balance, because the fetus is unable to concentrate urine, and so the urine, even though it's functioning, does not perform its full function, and it's not able to perform its full function even at birth. Sometimes we have to do palliative fetal surgery if there's some type of fetal or kidney anomaly that might affect the ability of the baby to excrete and have acid-base balance. Glomerular filtration rate is normally low at birth, and since the kidneys aren't concentrating urine, dehydration and overhydration can occur easily in our neonate. Again, if the baby doesn't pee within that first 24 hours, we need to notify the physician. Open urotube forms at the 4th week of embryonic development. It usually closes at what will be the junction of the brain and the spinal cord. Then you have the head forming at the junction, and the cranial end closes, and then your caudal end closes, which is the end of your neurotube. Y'all just learned all these cranial nerves. Brain waves are seen at week 8. The spinal cord is going to develop from the long end of the tube after it folds over on itself. And by week 8, we're seeing nerves throughout the body. By week 12, the baby's able to move all their extremities, respiratory movements, change position. They can do all kinds of things. Mom usually can't feel them move until 16 to 20 weeks, which is known as quickening. The multips can feel them sooner than the primips. Multips being someone who's been pregnant more than once. Primips is being pregnant for the first time. 16 weeks would be more like a possible butterfly, and usually a primip doesn't know what that feeling is. The sensory awareness of the fetus, they respond to touch on the belly. They respond to sound by 24 weeks. They can hear fully at birth. They can taste sweet at about the 5th month. They react to temperature changes. They will actually, if they're cold, they will assume a really tight fetal position to try to maintain their warmth. If you show, or actually they will if you shine your flashlight on mama's belly, they will actually be able to see that light in late pregnancy. And amazingly, as big as their head is, their fetal brain is only a quarter of the size of the adult, and will continue to grow for quite a bit longer. The endocrine system, the thing that concerns us most is that maternal thyroxine doesn't readily cross the placenta. Their thyroid may not be working correctly. They may have congenital hypothyroidism. So we want to do a Guthrie test or PKU test when they're 24 to 48 hours old to determine if they have hypothyroidism, because we can actually treat this at that very early age and prevent them from having any kind of mental developmental delays. Our pancreas, of course, is forming. And then our islets of Langerhans is developing by the 12th week, and they start producing insulin by the week 20. This is what gets us in trouble, especially with our gestational diabetic moms, is that the baby's producing insulin to uh, metabolize all the glucose that's being crossing over the placenta, and the higher mom's glucose is, the higher the baby's is, but he's producing enough insulin to really metabolize this glucose so that maternal hyperglycemia produces hyperglycemia in the fetus. But once the fetus is born and the glucose supply is just cut off drastically when the cord is cut, the neonate then has more insulin than he has glucose and can get into trouble with hypoglycemia. Our reproductive stage starts to differentiate by the 7th week and is fully differentiated by 12th week. Musculoskeletal bones and muscles develop by the 4th week, although they're very pliable. If we have any defects in the bony fusions, it can develop into spina bifida. Your flat bones of the skull develop throughout the embryonic period and childhood until they become adult. Usually by the 11th or 12th week, the muscles of the chest are trying to do respiratory effort, and of course we're seeing all the changes we just talked about earlier. At the integumentary system at 24 weeks, they have a lot of vernix cascosa on them, which is a thick, cheesy, sticky substance. At 32 weeks, they start depositing subcutaneous fat. When they're 16 weeks, they have handprints, toe prints, all of their identifying prints are formed. And then, of course, that lanugo we talked about earlier, they form it at about 12 weeks. By 20 weeks, it covers the body. The closer they get to term, the less lanugo they should have. Same thing with vernix. The closer to term they get, the less vernix they should have on their body. Our immunological system. You have IgG that crosses the placenta and provides passive acquired immunity. The fetus itself, by the end of the first trimester, produces IgM. And then you have IgA that is passed over as passive immunity through your breastfeeding. So if they're not breastfeeding, they don't get IgA. Making of twins, you have 1 in 43 births. You have the dizygotic twins that are 2 sperm, 2 eggs that develop into 2 different little human beings. They may or may not have any features in common. They'll be just a brother and a sister, or 2 brothers or 2 sisters. Monozygotic twins, on the other hand, are 1 sperm, 1 egg that divide into 2 babies. They are identically genetically, they are identical in sex, and usually look exactly alike.